Hi, I'm Amit Khera. I'm Director of Preventive Cardiology and Professor of Medicine at UT Southwestern, and I'm Chair of the AHA Committee on Scientific Session Programming. This is the 100th anniversary of the AHA. So, really our challenge was to really honor this history of cardiovascular medicine of the 100 years of the AHA and really get people excited at this pivotal moment for the future. We really started the meeting with some history, and the finale is about the future and what to expect and what to come. So we really wanted to leave people inspired, and I think we're doing that. I'd be remiss if I don't talk about our late breakers because those are always get the most attention. And that first day, we had some really fantastic ones. We had a study in 12,000 patients with diabetes looking at, more stringent blood pressure numbers under 130 over 80. And it did, in fact, show that that was better with few side effects. So it concurred with our guidelines, said, yes, we got to be pretty aggressive. The one that's going to get a lot of attention is the Summit trial, patients with obesity and heart failure with preserved ejection fraction. So very common shortness of breath related to obesity and giving tirzepatide, a GLP-1 receptor agonist type medicine, marked reduction in weight as they always do, but also a significant reduction in hospitalization for heart failure and cardiovascular death. So that's a big deal and a marked improvement in quality of life. So really an expansion of the potential use of these medicines in a group that doesn't have them. And I think the one that'll get a lot of discussion because it really tantalizing but unsettled, which is atrial fibrillation. Boy, almost 3 million Americans have it. Many people go for these ablation procedures to treat atrial fibrillation. And, in that, the question is, when you're done, do you stay on blood thinners or do we add this occlusion device to reduce the risk of recurrent strokes? It turns out the occlusion device, when you're off the blood thinners, you have a lot less bleeding expected, but it was non-inferior, meaning not worse than using blood thinners. There's a lot of nuances to every trial, and there were some complications of the procedure itself. So I think this will be one that is not settled at the end of a meeting, but has a lot of ongoing discussion, but a lot of food for thought, which is exactly what you hope. I think, I think that the one thing for me as I leave this meeting today is I think the future is bright. We're really at a pivotal point. I know we always say those things, but I think it was so tangible for me here to see that, particularly with the advent of AI, the globalization of cardiovascular health and a focus on prevention. It really is a pivotal moment. I think you're going to see so much related to prevention and cardiometabolic health coming forward. And I think we're going to see how we harness AI, the good, the bad, and the ugly, as one of the talks was. And there's so much opportunity. We should all be really excited about the future.
My name is John Sapp. I'm a clinical cardiac electrophysiologist in Halifax, in Canada, at Dalhousie University. And I do research in ventricular tachycardia and sudden cardiac death. We've just reported the VANISH-2 trial today at the American Heart Association scientific sessions. When a person has a heart attack, it leaves a scar in the heart, and that scar can lead to short circuits that cause very dangerous heart rhythms called ventricular tachycardia, or VT. VT is the most common cause of sudden cardiac death. We implant a defibrillator when we know that somebody's at high risk for VT. And one of the highest risks for VT is if you've already got VT. So a defibrillator can protect a person from dying suddenly by shocking the heart back, or sometimes it can pace the heart back into a normal rhythm. But we know that once a person starts getting shocks from their defibrillator, not only is it really an adverse effect on quality of life, it can be a very negative experience, but also the risk of death starts to go up. So we often have to suppress VT. The main options we have for suppressing it are either antiarrhythmic drugs, the main two being sotalol or amiodarone, or a procedure called a catheter ablation. We reported the VANISH trial, the original VANISH trial, in 2016. And in that study, we showed that if antiarrhythmic drugs aren't working in this population, it's better to go on to an ablation instead of going to much more aggressive, higher dose or stronger antiarrhythmic drugs. VANISH-2 trial was intended to answer the question of what should be our first-line treatment for VT. So in this study, we enrolled 416 patients at 22 centers, mostly in Canada, but also US and France. And the patients were randomly assigned to either treatment with antiarrhythmic drugs or catheter ablation. So the results are that we saw with catheter ablation a 25% reduction in the composite outcome of death, appropriate shocks from defibrillators, VT storm, that's a clustering of VT, or sustained slow VT that wasn't treated by the defibrillator and the patient had to go to the emergency room and get treated. Yeah, so that's what we saw. Each of those components of the primary outcome was either a little or a lot lower in the ablation group. Safety outcomes were fairly balanced between the two groups. Obviously, there are procedural risks from what I described going up in the heart with an ablation catheter, and similarly, the drugs also carry some risk. I think this means that we don't have to wait for drugs to fail before intervening with an ablation procedure. Now, that decision is always going to be an individualized choice. But what we now see is that the effectiveness of catheter ablation is at least as good as the drugs, if not better, and the safety profile is comparable. So I think that gives really meaningful data that physicians can bring to their patients when they're trying to make a decision about what to do next after VT has started coming back. Next steps in research, I think we need to figure out when we should be applying this therapy, whether it's drug or ablation procedures. Like how much VT should someone have before we start to think about doing more than just having a defibrillator? So that's a really important study that we're trying to get underway.